It's come there. Good morning, friends. It's a pleasure to be here in Bangalore at this amazing venue. And being the first speaker, I'm not very sure whether that's a boon or a bane. Anyways, this is a very vast topic, so I will start off with talking about traumatic brain injury management from the Brain Trauma Foundation guidelines to current practices. Very big topic, so let me see if I can do some justice. Every 3 minutes, an Indian dies in a road traffic accident, and India is the traumatic brain injury capital of the world, so that is not very good. And one of the other parts of being diabetic, etc., trauma also kills a lot of patients, and especially the young people in this part of the world. The normal brain anatomy, we know that the brain is 80%, the CSF is 10%, and the blood is 10%. And we also know the Monro-Kiley definition or the doctrine. But what we know is cerebral perfusion pressure is important, and that is mean arterial pressure minus the ICP or CVP, whichever is more. And cerebral blood flow is very important, which is CPP upon CVR. So every patient that has high blood pressure will not bleed, and every patient that has low blood pressure will not have ischemia because of the resistance that develops in the arteries. So classification of head injury can happen by morphology, epidural, subdural, intracranial, or diffuse concussions and hypoxic brain damage. EDH and SDH, we need to know that there are differences here. It could be concavo-convex. In subdural, it is bridging veins which are responsible, and it may cross the suture lines, and a neurosurgery consult can wait. We initially need to manage these patients. There will be brain parenchymal damage, and there will be more morbidity than mortality. Whereas in extradural, it is a biconvex lesion. It is because of the middle meningeal artery rupture. There is a lucid interval. It does not cross the the suture lines, and it is temporoparietal, and it needs an evacuation by a neurosurgeon immediately. And therefore, I would call it, don't compare lemons with bananas, because the epidural looks like a lemon, and excuse me, subdural looks like a banana here. And I've just made a stupid mnemonic: extra lemons, some bananas, E for extradural and S for subdural. So you might remember this in an easy way. Then we have diffuse axonal injury, in which this, I would say, is preventable if it has not occurred on the spot. Then because of the secondary hit, this happens. So we will look into how we can prevent that. We may also have basilar skull fractures, and we have raccoon's eye, battle sign, CSF, and otorrhea and rhinorrhea. So this is a patient who will never get a Ryle's tube through the nose. And then you may have something called as a brain sag, which is pneumoencephalus. And in this, the patient actually wakes up a little bit when you put them in Trendelenburg's position. So there is a little sag there, and because the air might move, patient might have postural improvement or gain. And then we have, if we have not done much, we can have 4 types of herniations that you might want to know. So how do I manage these patients and assess these patients quickly? I would do a Glasgow coma, I would do a CT scan, I would do an intracerebral pressure monitoring, multimodal monitoring, and maybe an ONSD. So I classify on the basis of Glasgow coma the head injuries into mild, which is 14 to 15, moderate, which is 9 to 13, and severe, which is 3 to 8. ICP monitoring not done for all, but there are indications if the Glasgow coma is less than 8 after resuscitation, or an abnormal head CT, and rapid neurological deterioration in the Glasgow coma would be indications for ICP monitoring. And if you want, you may have a Camino's a scope, or you might have a subdural bolt or an intraventricular drain. And when we measure the CVP, we look at the waves. When we measure the ICP also, we should look at the waves. It's not only a number, and we have the P1, P2, and P3, and when they summate, that is important. So the P2 is basically the intracranial compliance, and if that is the highest peak, that would indicate a raised ICP and global cerebral edema. We can do an optic nerve, which is very easy, and if it is more than 4.5 in adults or more than 4 in children, it would probably indicate that there is some raised intracranial pressure. Now is the time to do newer gadgets and use multimodal monitoring appropriately, where we are actually looking at even the brain tissue oxygen, and we are looking at so many other indices through this multimodal, and this is called as microdialysis. And here you are not only looking at the consumption of oxygen, but even the supply of oxygen, cerebral oxygen, blood flow, CPP, and the ways to actually tackle what is abnormal. So coming to the management, I will talk about the guidelines very soon, but what is the management in traumatic brain injury? And this is a very stupid cartoon in my opinion. Blurred vision is the cause of axe in your head, and you may need a second opinion. This is obviously head injury. And the management would again always be A, B, C, D, prevent secondary hit, which is important, a neurosurgical consult as early as possible. So there could be pre-hospital and emergency department managements, and we need to maintain oxygenation and blood pressure because it's extremely important to avoid hypoxia and avoid hypotension. If the patient has hypotension, for even 5 minutes, the patient would have 50% increase in the mortality. And if there is hypoxia, there would be 25% increase in the mortality. So basically, when you have both these together, there is no point in resuscitating this patient if you've allowed hypotension and hypoxia. Similarly, you would do the ATLS ABC guidelines, you would do a neuroconsult, certain important labs, ICP control, herniation avoidance, and keep the patient seizure free. Secondary hit or second hit to the brain is very, very important, and primary is what happens at the scene. And I would call this primary probably is God-given or by accident, and secondary is doctor-given. And if we allow the second hit, then we have not done our job well in saving the person. So what is the second hit and what should we avoid? There are the 8 H's that we should be avoiding in traumatic brain injury, and that would be hypotension and hypoxia, as I mentioned, hypoglycemia, hyperthermia, hypo or hypercarbia, hypercalcemia, hyper or hypovolemia, and hyponatremia, not in the same order. Now coming to the topic of BTF, the Brain Trauma Foundation, the latest guidelines were 2016, but the 4th edition has now been updated to 2024, and there is only one level 1 evidence. There are 7 2A, there are 10 2B, and so on and so forth. So it's very difficult to give you every guideline as a classification or recommendation, but I'll just go through the important ones and then tell you what is there beyond the guidelines. For decompressive craniectomy, yes, it is recommended, and this is all BTF. Shorter ICU stay, lower ICP, less ICP targeting interventions are expected to be beneficial, and this is recommended for decompressive craniotomy by the BTF. Prophylactic hypothermia, it says it does not improve outcome, but if you do it early and if you do it moderate, it may prevent the secondary brain damage. About osmotherapy, they've said mannitol, very, very select group of patients. So you might use it only to buy time before a surgical intervention happens. And there is not much evidence on hypertonic saline, though we use it almost on every patient in our day-to-day practice. Draining the CSF, they've said continuous drainage is better than intermittent drainage because the chances of infection are more. Drain the CSF for the first 12 hours only if the Glasgow coma is as low as 6 or 8. About ventilation, they've said that you must avoid hyperventilation, especially in the initial phase, unless again you are doing controlled hyperventilation for patients who are almost coning and have a Cushing's reflex, and you need to take them to the OT immediately. And they say, which is now, I consider it outdated, but they have still relied more on the jugular venous oximetry. But I think the multimodal has actually taken away this kind of technique. I've done about 10 or 12 in my initial days, and now we don't do it. We put it like a central line. Instead of going down, we go up to the jugular bulb, and that's how you can manage the oximetry. But again, that tells you only one side of the story and only 30% of the other side. About sedation, they said propofol is the best because you can have easy reversal, and barbiturate coma may be done for refractory ICP. Steroids are bad, and nutrition, you must achieve the goal within 5 to 7 days. Don't be too particular about trying to give them nutrition very early. Prophylactic antibiotics is an absolute no, but they have said please use VAP bundles because VAP is one of the commonest to occur in a head injury. DVT prophylaxis, everyone worries whether there is a brain injury here and there may be bleeding and can you start a DVT prophylaxis? So the guidelines is you can actually start enoxaparin, and if you really can't, in a stable traumatic brain injury, then which is not deteriorating, or may not need a surgical intervention in the next 48 hours, you can start it as early as 48 hours. Seizure prophylaxis should be given with any anticonvulsant, but within the, only for first 7 days. And we have had patients who are chronically for 10 years, 20 years on anti-epileptics, which was a wrong practice after a head injury without any structural damage persistent. About the ICP monitoring, it is indicated if the Glasgow coma is 3 to 8 and there is abnormal CT, and there are some other indications for a normal CT, but if there is an age over 40, motor posturing, hypotension, and the ICP remains above 22. CPP is maintained at 60 to 70. Advanced monitoring, they have said that multimodal has no mortality benefit, but who cares about only mortality benefit? We need to actually understand and manage the patient well and prevent secondary hit. About the BP, they have said keep the target between 100 to 110 systolic or maintain the CPP between 60 to 70. So these were the BTF guidelines that I have just given you encapsulated. And now I will just touch upon in the next 2 or 3 minutes on all the newer last 4 years studies that have been done in traumatic brain injury. I've pulled out almost 10 to 15 of them. So very quickly, COBE is one study which looked at hypertonic saline infusion versus standard care, and they found that 20%, they didn't use 3%, they used 20% hypertonic continuous infusion, and it found no benefit over the placebo group. Then they studied the hypertonic saline, which was lower concentration, which we use 3%, and they said there may be a practical therapeutic benefit here. So yes, hypertonic saline still needs more data, but it can be used. About the decompression, all students must definitely know the DECRA trial, which was in 2011, and it said that early bifrontotemporal decompressive craniectomy decreased the ICP, decreased the length of stay, but was associated with more unfavorable outcomes at 6 months. So what they said is you may save a life, but the morbidity at 6 months is much worse in patients who had a decompressive. I think this is true because they lived till 6 months. If you didn't do it, they probably would have died. Then came the rescue ICP management, and that was the decompressive craniotomy again in intracranial, and it was associated with lower mortality. So there was some benefit here. And they said that you must probably, with both these studies, try and do it. And then the latest is the STITCH study into which came much after, and it again says that there is a strong case for operating patients with intracranial hemorrhage in a Glasgow coma, which is 9 to 12, not very severe, not very mild. As simple as using an oral beta blocker, propranolol. This was a Khalili study, very odd name. But it's a in severe cases of TBI, there was improved survival at 6 months, better functional outcome if oral propranolol was used. So that is quite interesting. But then they said they became greedy and they looked at propranolol along with clonidine to try and see what happens with the traumatic brain injury patients. And here they said that both of them do not have a synergistic effect and it may not be used. So we still don't have what data we need to do. Then came the Annexa 1 trial, and here they say that if the patient was on receiving factor 10A inhibitors, then I'll just take a minute or two. 10A inhibitors, then giving the andexanet would have a better outcome in reducing the size or the increase in the hematoma. Hemotion is a nice study between liberal and restrictive transfusion strategies, and again it showed no difference in the 6-month mortality or the benefit neurologically. EPO-TBI is using erythropoietin. They've tried everything in traumatic brain injury, and they said that it did not reduce the number, but there was also a quoted study of impact TBI, and it showed significantly lower 6-month mortality. So we are more and more confused with more and more trials. This is another trial which showed very positive results, but I don't believe in this. Prophylactic for VAP, they said in traumatic brain injury, VAP is common, so you give them ceftriaxone. And just giving ceftriaxone itself is going to reduce your ventilation, VAP, number of days and ICU state. Looks a little dubious here. And then they said the polar study, which is prophylactic hypothermia, again not really useful. So in summary, if you are a neurosurgeon, then it will be compression, decompression, sedation, CPP, osmotherapy, hyperventilation, phenobarb, and hypothermia. And this would be probably a stepwise approach. But what we do as intensivists is the tier 0 to tier 3 standard measures, prevent your secondary hits, hyperosmolar therapy, CSF diversion, sedation and analgesia, paralytics, normothermia, and then finally decompressive craniotomy, moderate induced hypothermia, and barbiturate coma. So you can actually go through the entire spectrum in summary. This is a very nice chart. We like ABCDs, and this is an airway with spine control where they have given head high and whatnot. Breathing, keep the CO2 between 35 to 40, O2 between 100 to 150. Circulation, keep the right blood pressure map above 80 and systolic less than 160, and CT scan, coagulopathy, disability, etc. I have just made my own mnemonic here. A for airway, B for breathing, C for circulation. I can't dare to change that. But D for decubitus, because these patients long-term ICU care can develop pressure sores. E for eye care, we must tape these eyes. E, G, and epileptiform care. F for Foley's, because we need to put that in. G for gastric, we need to feed these patients. H for avoiding the 8 H's, and I for infection control and IV fluid monitoring. So this is my ABCD till I. I could have gone more, but I think for want of time and lack of my knowledge, I couldn't go till Z. So I conclude with a small poem here. Please don't laugh at me. It's early morning on a Sunday. Don't be hyper and don't take tension over management of TBI and hypertension. In TBI, the brain may not auto-regulate. More importantly, prevent hypotension and hypoxia as the surrogate. To keep the skull open or the brain cool, we need more data and statistical pool. Preventing the 8 H's is an alarm. Remember always to do no harm. Prevent the traumatic brain from a second hit. Do not routinely give anti-epileptics unless there is a fit. Carry out your ABCs from brain damage to disposition. Only then will a traumatic brain injury victim go home in a great condition. Thank you, friends.
Thank you, sir. Thank you very much for the lucid presentation. And thank you again for taking us through all recent literature and evidences and give a short and crisp summary. Thank you very much, sir.
Thank you. Sorry if I exceeded a minute, but this was very vast. Thank you.
So we can take any questions at the end of the session. So we'll go to the next session.
No questions?
End of the session we'll take.
Okay.
Thank you, sir, for that wonderful presentation. Always you end with the humorous your way of ending the session. So after the great start, next we'll move to another topic. As we know, any trauma patient, 50% of the patients they die on spot. We know that, and whatever we do, it is only to save the other remaining 50%. So when we are having this kind of scenario, let us move to the next topic regarding improving the trauma survival from Good Samaritan to the hospital care. I would like to invite Dr. Swarna Deepak Kuragaila, madam. Swarna Deepak Kuragaila. He is the consultant and intensive care medicine and also the lead consultant in infectious disease, professor from Apollo Health City from Hyderabad. So I would like to invite sir. Please.
Thank you, Chairperson. So at the outset, I would like to thank the organizing team for giving us the opportunity, and it's a pleasure to present before our teachers, Madam Suhasini Madam, J. Srinivas sir. And so when the topic was given to me, it was in fact, I was so confused and I called Rangappa sir and Bhuvana madam. So what is this topic? They were also equally confused. You find out and let me know. So the speakers before me and after me, they'll be talking about more core subject topics. So this is more about some couple of abstract topics. So this is one of my personal experience. As we go to a pilgrimage, one of the most famous place, Arunachalam. So this was a few years back. I went with both my freshly born twins, along with my wife and my mother and those people. So we were just about to enter the place, the Ramana Maharshi Ashram. Outside of it, we were just entering. There's a collapse of the parapet. So there were some workers who were working. Suddenly the entire parapet, because it's a rainy season, entire parapet got collapsed. So it was such a chaotic time. So I don't know what to do. The people don't know what to do. I had some medical knowledge, but I don't know how to retrieve them. So everyone, I'm like, it was such a chaotic time. There's roads were blocked. So finally we thought we'll pull one of the workers from the entire rubble. So he was unresponsive. I could not do anything without any gadgets, anything, nothing is there. So then we tried to stop the vehicles on the way, autos and cars. No one was stopping. Finally, we could ask my driver to pick him. I actually asked my both the kids and wife to come out of the car, and then we made the person into my car. But there was no space of the car to go forward. So entire road is blocked. No one was allowing the car. So it was such a nightmare. The entire trip was, by the time we went to the hospital, the primary healthcare center, there's no one who knows how to intubate. In fact, I know it, but there's no ET tube, there's nothing there. So we lost the patient ultimately, such a bad thing. I think maybe around 21-year-old boy, we lost it. It was such a nightmare. I think similar thing occurred to the innovators of the ATLS, right? So if we could solve this scenario, maybe one life we could save it. I think the overall problem would be gratified. You know, as I think Kusrav sir already told, we boast about the first rank in the trauma. In all sort of trauma, we are the first ranker in the world. And both for a country which has a like developing one, the economics are on the lower side, it's a huge burden on our society. So can you spot the ambulance here? So even if you are the person who is sitting in the car before that ambulance, you are helpless. You can't do no, you can't move your car, right? So it is such a helpless situation for you. Unless until you are going to solve the overall society, the organization, the people behavior, this is not going to be solved in a kind of jiffy of a second. See, as you know, the time is extremely vital in a trauma, especially the pre-hospital. You can see this first hour is the one where there is a maximum mortality. Whereas if you could prevent it, if you can quickly bring this patient to the definitive care, I think you save a lot of lives. And as you know, the first peak of death has a major injuries. People die, you cannot do much about it, but this is the one where you can actually save the people. So, as you know, the pre-hospital phase, it's a combination of the layman awareness about the trauma, the importance of saving the timelines here, fastly bringing them in a proper fashion, in a proper handover to the hospital. And this involves overall awareness of the patient, and at the same time, once they give a proper information, the hospital also can do a proper readiness there. It comes in these headings, like you need to have a proper organization, both at the government level, the traffic police, everyone who helps you, and ultimately they need to have a basic idea about the basic life support skills. So that's the reason at Hyderabad, at least from the ISCCM side, we do at least 2 public awareness programs and BLS every month. And ultimately, if you are a more rich society, you can go to the helicopter ambulances and all. So these first 10 minutes are called as platinum 10 minutes of the first golden hour. So you do these things. Obviously, I think Kusra sir has covered this. You do the basic ones. If you have someone who has this knowledge, you can definitely do. Quickly do a triage as well. Especially when you have a mass casualty, like I told you the setting, you do a proper triaging. You all know how to you do the triage, and quickly you shift the patients who require to the hospitals. I think it is superfluous to tell how to do the triage, but the basic ones, when you are in an emergency, you can quickly use these things. If they can walk, definitely you can wait. If the patient is not breathing, obviously you're not going to do much about it. And quickly assess the circulation. And the problem of the transport, as I showed you the picture, you have various types of transport, right? In India, the road transport is still the predominant one. You know how to transport the injured persons. As you have various ways of transporting, like whether you have a drag technique, whether you are scooping it or piggyback, various techniques. But every layman should know how to do this transport of injured persons. Once you come to the hospital, I think the next speakers will be covering it, but you need to know there are various trauma centers, both at the level 1, level 2, level 3. There is various levels of maturity of the trauma centers. So if you're fortunate that you live in the vicinity of the level 1 centers, that's good. But as we see in the later part at the government level, both at the state government and the central government, they are trying to establish the level 1, level 2 and level 3 centers. Once you come, obviously you're going to do the ATLS. So you have various modes, like exclusive model is when you have a specialized center sitting where all the patients will be shifted to that. Like this occurs in the highly developed countries, the patient's load is less, the vicinity of the overall country is less, like maybe Netherlands, Switzerland. These people, they can afford to do it. But ours is a country where the traffic is difficult, the resources are less, people are ignorant. So they're bothered about going to their office rather than someone dying in the ambulance behind, right? We all know about it. So inclusive model is where you develop the existing setups, improvise the skills of those persons who are actually working in those primary health centers, the level 3 centers, and then you make sure that there will be coordination, the communication between all of the centers. So this is called as inclusive model. Obviously, to have this model functioning, you need to have a functioning road. Traffic needs to be controlled, like in Hyderabad, at least I think I know there are green channels for the transplant, but I think there's recently last month when we attended a meeting, they were contemplating a green channel for the major trauma, but I hope once that materializes. Distance is one of the major worries, like the present government guidelines, they stay at least within 50 kilometers, you should have at least level 2 or level 3 centers, whereas within 100 kilometers, you should have a level 1 center. Weather is not something in your hand. So coming to 3 or 4 controversial topics, do you need to have a physician at your hand or non-physicians are better? How many of you feel non-physicians are better than physicians in a major trauma? Yeah, at least Sunil sir. So coming from the senior physicians, that's something to listen to. There was a world over, I think the experienced paramedic is always better than the inexperienced new physician. So it makes a difference. So here the point is the first pass intubation, first resuscitation, the first 10 minutes is vitally important. So having an experienced person, whether it's a physician or a paramedic, is very important. And especially the pre-hospital period, where most of the 30 minutes you are spending in the vital period, spending in the out of the hospital. And everyone in the periphery, they need to know how to assess the ABCD. Even if you're keeping an MBBS graduate at the primary health center, they need to know the basics of ATLS and the ABCD. Here again, the concepts are changing. We used to be quite stringent about the ABCD, the structure. Now the concept is you resuscitate first before you keep on trying to intubate, especially when you have juniors, and have a fixed format of handover, like S-bar format, so that the definitive care, the hospital will be ready with it. And the time spent on scene, the lesser the time, the better. As you can see, the guidelines state that 20 minutes is the period. If you see the Netherlands, any place there's an accident, they can shift the patient to the definitive care, the level 1 center within 20 minutes. So it's far-fetched in India, but at least I think we should strive towards it. Mode of transport, still the road is the one which is there, but as you can see, the government has started the trains as well. So there's a train-based ambulance from the government as well. And monitoring the transport, at least the basic things from the layman, the paramedics should be keep monitoring the transport. And this is the latest one from the government. So the government has started the capacity building for proper development of the trauma care facilities. This is a busy slide, but you can see there's a huge incidence of trauma and the mortality related to the trauma. It's especially concentrated in the busy states. As you can see in the hilly areas like Arunachal Pradesh, Nagpur, there are less trauma because less vehicles as well. But there are the areas where the helicopter-based ambulances plays a role. So this we have seen. So the mortality seems to be quite disproportionate to the number of accidents. So the policy of the government states that the people should be trained in the initial stabilization. People should be trained in the rapid transport. And you have this, right? This is the golden quadrilateral, the highways. So this is the government's initiative. It started in the 9th 5-year plan, and now it's the 12th 5-year plan. So they are establishing the outer ring road, the highways, the trauma centers. In fact, in Hyderabad, they started recently, I think last year, they started 16 new centers where you will have a ORR, the outer ring road trauma centers, where quickly they pick up the patient trauma on the highways, because this is the quadrilateral where there's a highest incidence of the trauma. They stabilize the patient quickly, and this is a partnership between the government and the private hospitals as well. For example, in Hyderabad, you have an Apollo and Yashoda, both of them are dividing the various trauma centers. So this is the guideline where say for each 1400 kilometers, you have at least 2 level 1 trauma centers, 6 level 2 trauma centers, and minimum of 28 ambulances. So this has been, I think, a surviving initiative by the government, seems to be helping well. So we always remember that creating the infrastructure is not enough. The system is which is important. So creating an awareness and training of the people is more important than developing the building. So last one, I think the same place, this is one, I think this is the way you need to transfer the patient who had an accident. You need to have a proper handover of the patient quickly. This is being assessed by an MBBS graduate, right? So whether it's an MBBS graduate or a post-DM candidate, the person who is in the initial 10 minutes is the one who's more important. So you have a proper handover. And ultimately, once you transfer, I think at least the one noble initiative what we can do is make sure that people are aware of clearing of the ambulances. I think this is what is going to save life. Thank you.
Thank you, Dr. Deepak, for this lucid presentation, taking us through many logistic issues. I could feel a lot of challenges we have rather than the simple solutions. And good that the traffic jam is not in Bangalore, and the last ambulance is from the Bangalore. Thank you for.
Thank you.
Please, only one.
Samaritan law in India, and that is very useful. So people may be very worried about using it or helping people on the road, but this Good Samaritan law actually prevents any harassment for helping a person on the road. So that's one thing which is very good and path-breaking in India. Finally, we have that rule since 2016.
Yes, thanks.
Just one quick comment. Just want to clarify why about the thing that I told. I raised my hand. It is only more from the perspective that, as you rightly said, an MBBS doctor may not be enough. You need to anyway give them some training for managing these kind of traumas. So it's probably easier to have an EMT technician, and world over, I think that is what is being done. So if you have a good EMT technician, they're as good as having a doctor. That's what.
Thank you for adding the comment. So we'll go to the next talk.
Good morning. More of trauma cases, and a lot of lives are being lost, and every minute counts in acute trauma care, and the doctor who gets to see the patient first will have the best opportunity to save the life. And today I would like to invite Dr. T. Suhasini, HOD and ICU in charge, SLG Hospitals, Hyderabad, to give us more information on the acute trauma life support. A warm welcome to you, madam. Over
Thank
to you.
Thank you for your kind invitation. And at the outset, I would like to thank Dr. Rangappa and the entire team of JIX24 to provide me this opportunity, and their hospitality, which is really wonderful. And today I'm here to discuss ATLS, what's new. So, as any trauma protocol starts with a bad incident, and it was James Steiner, who was involved in a tragic airplane crash along with his family, and suffered, delays, undue delays in the administration of initial treatment, and also in the primary care center, where his wife died, because of the undue delay of 8 hours. And so, that instigated him to start the ATLS course in 1980. And this, is widely attended all over the world. in more than 86 countries and more than 1 million students completing the course. And the original intent was to train doctors in small groups and were not exposed to trauma care at all. But now it has become the standard of care in the first hour of trauma care, and be it in the isolated rural area or in the state-of-art trauma center. So wherever it is, the care is the same. So this has been discussed in the previous lecture. All the doctors and technicians should be trained for the adequate support of the injured patient. And two forms of courses are offered to expand the program, and that is one electronic and the real one. So both offer more extension of the courses to more people, and so more people can be useful for attending these patients. So the 10th edition of ATLS is the most innovative and creative update, and it is formed on the key changes which are based upon the recent advances it has been formulated, and in 2018 it has been changed, and emphasis is laid on the trauma team. So it's a team which is very, very important, and it includes a new trauma teamwork section at the end of each chapter. So the trauma team concept is imbibed in every chapter of the ATLS program, and the new appendix focusing on the trauma resource management is also laid in the ATLS program. So the extended pitfalls in each chapter to identify the preventive measures meant to avoid pitfalls are also stated, and completely revised skill stations based on unfolding the scenarios. So the more practical approach of training the people is also thought important, and then it was revised. And so additional skills for hemorrhage control and the new coma scales, and you have update on the terminology, and new photographs and illustrations have been updated in the new ATLS. And when we go chapter wise, we can see in the initial assessment, the key tenet, the ABCD approach did not change much, and it is still the basis for the initial evaluation of the patient. It continues to support prioritizing the rapid assessment of and treatment of the life-threatening airway breathing problems and circulation problems. So it's very important, initial airway stabilization with C-spine control is still very, very important, be it at the primary care area or in the tertiary center, wherever it is. And primary survey and resuscitation should be done simultaneously. So just writing, documenting all the things without resuscitating the patient is a waste of time and lose out on the golden hour. So it's very important that we imbibe the concept of primary survey and resuscitation should be done simultaneously. And the ATLS recommends only 1 liter of crystalloid to be provided during the initial assessment, and blood products should be started immediately in patients who are not responding to this 1 liter. So it's very important we minimize the amount of crystalloid given to these patients. And airway and ventilation, the rapid sequence intubation has been changed to drug-assisted intubation. So this is drug-assisted intubation is particularly useful in patients with intact gag reflex and also in patients who have sustained head injuries. And the use of video laryngoscopy is also stressed because it's available in most of the advanced centers though, but if it is available, it's a boon to use them to clearly visualize the laryngeal inlet to intubate to get a definitive airway. And again, the trauma team is again stressed. So infusion of, in the shock chapter, they identified that infusing more than 1.5 liters of crystalloid is associated with increased mortality, and large crystalloid transfusion is not an alternative to hemorrhage control. So early hemorrhage control with external pressure or use of tourniquets has been stressed upon in extremity injuries with severe bleeding. When bleeding is not controlled, you can use tourniquets as well. And the classification of shock table has been amended with inclusion of base deficit and the need for blood transfusion or the massive transfusion protocol is included. So this is based upon the retrospective review of severely injured patients in German trauma registry. They found a variability, huge variability between the clinical findings and the ATLS shock classification. But when they included base deficit, they found which is easily available. Most of the ABG analysis are available all over, and so this inclusion of this decrease the variability. And also it proposes the use of early use of blood and blood products in moderate to severe bleeding. And massive transfusion protocol, that is massive transfusion is nothing but more than 10 units of packed red blood cells in 24 hours or more than 4 units in 1 hour has been suggested for patients with grade 4 shock. And management of coagulopathy is very, very important because coagulopathy is a component of lethal triad of trauma, and also most of the patients, elderly patients, are on anticoagulants. So coagulation control, like, with reversal of anticoagulation medications also is very, very important, and the chart has been proposed. And thromboelastogram and ROTEM have been proposed to pinpoint the precise coagulation deficiency, and the role of tranexamic acid is also said. So here we can see the base deficit is also added as a component of the shocks table, and also the need for blood products, like, usually in the severe class 3 and class 4, where you require to give blood and blood products, and then in the massive transfusion protocol has to be activated in class 4 patients, like, definitely. So this is the recommendation. And then early administration of tranexamic acid has safely reduced the risk of bleeding in trauma patients and highly cost effective. This is the landmark crash 2 trial, findings, and they said, beyond 3 hours of injury, it's a waste of time, maybe, it may not be useful, and on the top of that, it could be harmful also. So beyond 3 hours of injury, please don't stress on the use of tranexamic acid. And also in seriously head injured patient also, tranexamic acid is safe, and also treatment within 3 hours reduces head injury related death. And it's shown in mild to moderate injuries, significantly it reduces the 28-day mortality. And in thoracic trauma, in the list of life-threatening injuries, the flail chest has been taken off, and tracheobronchial injury is included. So the flail chest is out and tracheobronchial injury is in. And the standard teaching in the treatment of tension pneumothorax is to approach the thoracic cavity in the second intercostal space in the mid-clavicular line. But now it has been shown and changed to the fifth intercostal space in the mid-axillary line. So, it says the case studies, the cadaver studies have proven that access to the thoracic cavity is better in the fourth or fifth intercostal space as compared to the second intercostal space for the draining pneumothorax. So this is now recommended as a protocol, and it is changed. And open thoracostomy with a finger decompression of the chest and eliminate tension pneumothorax totally before inserting the chest drain is also recommended. And E-FAST, of course, aids in the diagnosis of pneumothorax rapidly, and E-FAST, it's a modification of the FAST, where in the thoracic cavity is looked upon for identification of the pneumothorax is also proposed, and then it is definitely shown as a picture. The finger thoracostomy, to evacuate the pneumothorax has been proposed. And for the chest trauma hemothorax, 28 to 32 French as compared to 36 to 40. So 36 to 40 size tube is very big, and prospective analysis has shown that 28 to 32 French is good enough to evacuate the entire hemothorax without any retention. So, and also they said with advent of the CT angiograms and CT aortograms, aortic rupture identification also has become very rapid, and the use of beta blockers have been proposed to control the further damage occurring after thoracic rupture. And traumatic circulatory arrest algorithm has been proposed. This forms a treatment care plan for the patients with severe trauma who require present with traumatic circulatory arrest. I'm sorry, this could be a bad slide, which is difficult to visualize. And also in abdominal and pelvic trauma, palpation of the prostate gland is no more recommended, and high riding prostate is no more reliable for identification of the patients who should go undergo further investigation. And it has been proposed that pre-peritoneal pelvic packing to control pelvic hemorrhage and severe pelvic injuries with uncontrolled hemorrhage has been proposed as a successful technique and is included in the guidelines. And the flow chart for the pelvic hemorrhage has been amended, and it is shown that pre-peritoneal packing is also included, and the role of angiography is also proposed. So if you have an option or in a better center, you can do all this. In the spine trauma, then it has been shown that spinal cord can never be immobilized. So it's only, the terminology is changed to spinal motion restriction or restriction of spinal motion, not spinal immobilization. And then the Canadian C-spine and the Nexus criteria are proposed for identifying which patients require imaging. So it is not all patients should undergo imaging, it's very difficult to transport the patient to the CT scan room, and in fact the CT scan room is a graveyard for a sick patient. So that is the reason the Canadian spine rule and then the Nexus criteria can be used to identify the patients who to require scan. And the corrected myotomy diagram has been proposed, but it's not very important for us in the management. And head trauma, like new Glasgow Coma scale is introduced in the 10th edition, which stresses the importance of numerical components of the score. And the new designation NT is not tested, to be used when a component of the score cannot be assessed. And also similar to the Brain Trauma Foundation guidelines as Dr. Kushro has proposed just now and shown, and then it says avoiding prolonged hyperventilation to PCO2 less than 25 should be there, and then systolic blood pressure should be maintained more than 100 for patients 50 to 69 years, and more than 110 years it should be, it's more than 110 for patients 15 to 49 and more than 70. And then anticoagulation reversal and procedure prophylaxis has been told about, and then you have this Glasgow Coma scale, which is another designation as NT, which is not testable. And then the mild trauma should include even patients belonging to GCS score of 13. So GCS score 13 is included in the mild trauma, but the trauma team activation should be there if the GCS is less than 14. So the activation should be done if the GCS is less than 14, and the team should be and there's an algorithmic approach which is newly proposed in the 10th edition for managing my patients with minor head injury. And musculoskeletal trauma, IV antibiotic should be given according to the weight to reach the site of injury, and highlights the risk of bilateral femur fractures. Bilateral femur fractures are associated with higher blood loss and then significantly increased mortality, and then the trauma team should be. So in thermal injuries, instead of 2 to 4 ml of fluid, it says in adults it is 2 ml per kg. I'm sorry, I'll take one more minute. 2 ml per kg body weight per percentage of burns. For children, it is 3 ml, and for electric burns, it's 4 ml. Titrated to urine output of 0.5, 1, and 1.5 in adults, children, and patients with electric trauma. And the pediatric, nothing, needle thoracentesis is not changed. It's still in the second intercostal space. And limiting crystalloid and use of more blood products has been proposed. And the Pecan criteria are used for head CT guidance. And then trauma in pregnancy, the vaginal pH of more than 4.5 is considered indication for amniotic fluid leak. And the geriatric trauma, as has been said, they have more comorbidities. The 5 comorbidities, COPD, IHD, diabetes mellitus, cirrhosis, and coagulopathy are associated with twice the mortality. And then pelvic trauma is very, very associated with high mortality of 4 times the mortality, and even though they have stable fractures, they need blood transfusions. One has to think about. There should be a low threshold for imaging, and anticoagulant use should requires reversal, and the table has been proposed in the new edition. And as Deepak has already told, transfer to a definitive care. Please don't delay the transfer because of the need for CT or the unnecessary investigations which do not guide us to any care of the patient. And then SBAR template for communication during transfer of the trauma patient. And I suggest ABC SBAR, the airway breathing circulation, and then SBAR, 2, 1, it's all done. Anyway. Thank you for and we are awaiting 11th edition. The meetings are done maybe in October 24 they have concluded, and we'll come up in 2025 with a new guideline. Thank you very much for the patience. Sorry, I've used an extra minute.
Thank you, ma'am. Thank you very much for your lucid presentation. So we'll go to the next talk.
Good morning. Regarding the CT scan, the diagnostic modality, whenever we have a patient with trauma, as always there's a mixed opinion whether to go for a whole body CT scan or do the scan pertaining to the symptoms of the patient. So to give more insight to this topic, I would like to invite Dr. Srinivas Jakinaboyna. He is the critical care physician, pain management specialist, anesthesiologist from Care Medicine, Hyderabad. Welcome to you.
Thank you, sir, and good morning all. And thanks to Dr. Pradeep Ramgappa sir and JIX team for having me here. And today's my topic is on whole body CT imaging versus focused imaging, evidence-based medicine. So as Suhasini madam has already mentioned about the trauma patients, and today we are discussing on trauma in the morning session. So should be a patient having a trauma come to the hospital emergency, so should I do now a patient who is having a fractured femur or tibia, should I do a whole body CT scan if the patient is conscious or unconscious? So let's discuss what are the indications, what are the evidence-based medicine. So we have, when most of the patients with motor vehicle collisions are 80%, and Usually in these patients with high injuries, most of the patients have a head, neck, face and chest injuries are there. And these injuries are also very lethal. Like they may have vascular injuries, and also have, we are into like damage counter intervention radiology for unstable trauma patients. And also when we see clinically, we may miss some of the things because of their poor GCS or alcohol status or other conditions, or the pain is more at the different site, as madam was mentioning about nexus criteria. So we may miss the scanning of when we do a specific area. So what we do is whole body CT scan, means they do a scan from the whole body from the head to toe, and now they have also mentioning that pan CT scans, they include the upper limbs and all the limbs also from the head to toe. And they do first they do a normal scan, non-contrast scan, followed by the contrast scan from the chest, abdomen and the pelvis and wherever is required. Both they take arterial and venous phases evaluation, and as soon as the patient comes to the emergency, we do a fast and then resuscitate the patient. First, the resuscitation is the most important thing, and without resuscitation, if you take the patient into the CT scanner room, we may lose the patients. So we'll discuss mainly about the comparison and the modality, safety, time, cost, radiation exposure and outcomes. So there are, most of the studies here are on observational studies only. Only very few are, one or two are randomized studies are there. And this is one of the study where organ selective CT versus whole body scan. Here the inclusion criteria in this is the long bone fractures, major pelvic injuries and spinal cord injuries. And if you see into the vital signs, GCS less than 12, and they are under influence of alcohol or drugs, systolic blood pressure less than 100, respiratory rate is either low or high, and patient is having tachycardic. So there are signs of shock in this patient. So these all patients are in shock or major injuries. So here they divide, either the trauma team consists of trauma surgeon, general surgeon, emergency room physician and trauma nurse. They decide on whether this patient needs what type of scanning. So here this is an observational study. Here most of the, if you see into this, most of these patients where shock patients were done is a selective scan, and the non-shock patients, if you see into this whole body CT scan, it is a non-shock is around 11.4%. So in this, if you compare the baseline data, ISS is injury severity score is high in whole body scan, and also there are no other differences, but here the penetrating injuries are more in the selective scan things. So they compared the data of the CT scan data from the ED to the CT scan room, because this as a protocolized system, then the whole body CT scan took less time for ED to CT, CT to diagnosis. And if you see into these selective scans, 47% of these patients had landed into other different type of scans like CT scans. So because they would have missed some other diagnosis, so they have done it. This is almost 47 is a very good number. And the exposure, if you see into the radiation exposure, in the selective scan is higher because this patient went again to the CT scan room for the radiation exposure. So this is a purely an observational study. So decision by the trauma team, no randomization of the patients. So this is one of the REACT trial, which is randomized trial. Here this is intention to treat analysis. Totally were 539 patients in each group, and 4 in Netherlands and 1 in Switzerland. The level 1 trauma centers, and which is done from 2011 to 14. Here the criteria was at least one of the following thing, like the same respiratory distress or in shock, or the patients having the same more long bone fractures, and patients are sick, low GCS. So these are the patients they have chosen, similar criteria to the previous things. So they found that ISS was high in these patients with a whole body CT scan, and hemoglobin was also low. There is no significant difference in the age, blood transfusion, blood trauma, blunt trauma, traumatic brain injury. The 46% of the patients cross over to the intervention group because it is an intention to treat analysis. So that, but they did not, when calculating, they did not calculate it separately, but they considered in the same group, as you know, and they looked into it. Here also they found that the emergency to CT scan, CT to diagnosis is less in compared with in whole blood, whole body CT scan. Time spent in ER is, there is a trend to decrease time in this group, and the missed injuries are higher in the selective CT scan, and the events during scanning were little higher in patients with whole body scan, but not statistically significant. If you see it, compare in the cost in euros, like finances are also, this is not significant between these two things. So we also can, what we can do is, we have done a scan, if you do a selective scan for each organ, the price will be very high. So you, in your hospital in emergency, we can have a separate price for a whole body CT scan in the lesser price so that the patients can benefit. In hospital mortality, there is no difference, but the radiation exposure was higher in patients with whole body CT scan in this group. So comparison of, it's a meta-analysis, but here they, while looking into it, they have in a study design, they took randomized trials and observational trials, and also they have a primary and secondary outcomes in these patients. But they could not find any randomized trials because till the data was taken up to 2012, and they have a lot of cohort studies, and the thing is they also compared with the whole body CT scan with a selective CT scan, and sometimes they have also done X-rays also they have compared. So the quality of the studies were poor, and they found that the mortality is less in whole body CT scan, and if he looks into the two studies where Hutter study and Daiki's study, there the very statistically very highly significant. They taken off that two studies and they have looked into it. They still found out the mortality is less in patients with a whole body CT scan. The time spent in ER also is less, and they looked into the ICU, ventilator duration and hospital length of stay. In these patients, they found that the ICU length of stay is higher in patients with the whole body scan, and the ventilator duration is higher, and hospital length of stay is also higher. But the mortality rate is less in patients with a whole body CT scan. Then they looked into again into the data, why this, so they found that firstly these patients are having a reduced mortality rate in these whole body CT scan patients, because those patients who were done a selective CT scan, their patient had death early and their length of stay is low, but these patients had a reduced mortality, so their length of stay is very high. And they are more, as injury severity score also is high, they are led to multi-organ dysfunction syndrome, multi-organ failure, and longer duration of ventilation. And there are also continuous improvement of CT scanning technology, effective dose has decreased significantly. So all studies in the meta-analysis were observational, non-randomized, and there are gross baseline characteristic differences. And survival benefit always depends on the trauma resuscitation, how you do. It doesn't depend on the CT scans, what you do. But of course, CT scan help us the diagnosis, and cannot rule out other residual confounding factors like scanners, scanning methods, inclusion criteria, location of the scanners, or potential publication bias. So this is one of the meta-analysis which was published in 2024. So they found that this they found that they induced included randomized studies, observational studies, and they found that by whole body CT scan, they could find out more of head injury, head, neck and facial injuries, especially vascular injuries and chest injuries, better than in a patient with the selective injuries, abdominal injuries, spinal injuries, extremity injuries and pelvic injuries. So these were the data they have given when compared with the selective scans. The mortality is almost, there is no difference in the mortality whether you do a selective scan or the whole body CT scan. So the take home points is modality. So whether the better is, as you have seen the data, almost around 50% of the patients, again scan was done in these patients in a selective scans. I think whole body CT scan is a better, but safety is most important. So there was data which in the patient who is having a shock, that is systolic blood pressure less than 100 and they have a lactate of higher lactate and they are in the resuscitation phase and their heart rate was high, they found that even these patients, when they have minimally stabilized and they have shifted, when they feel safe and shifted to the CT scan room, there is no mortality difference, but they could identify some issues and they could treat those patients better if they are safely resuscitated in the ER and done in this. And there are a lot of studies, data also is there, whether a CT scan room area, CT scanner next to emergency or in the radiology suite, there is no mortality difference. And the time, as you all know that the time is in a shorter time, we can do a better diagnosis with a whole body CT scan. And the cost, actually if you do the cost in the euros, we have seen it is less, it is almost equal, it is not high. But if you can put a package in your hospital, Indian hospitals, and we can do a better job in these patients. And radiation exposure, and if this patient undergoes repeated scanning, the radius exposure will be higher when compared with the whole body CT scan when done this. And outcomes always depends on the diagnosis and the treatment. It doesn't depend only on the CT scan. I think once we get a diagnosis and proper resuscitation happens, the outcomes will be good. Thank you.
Thank you, Dr. Srinivas, for the short and crisp presentation and taking us through the various literatures. So we'll go to the next session.
Intensive care is largely determined by following guidelines. However, there are some myths in our clinical practice also. I would request Dr. Coagulopathy to bust some important myths in intensive care. Welcome, sir.
So, very good morning to all of you, to JIGS and all my senior faculties and all my mentors present here. So, day before yesterday, I was just going through the talk by Dr. Suresh Ramasubramaniam. So, what he was saying in that pro and cons debate actually, so within 100 of myths lies the truth. And as we all know, so unless until we to know the truth, actually you have to discover a lot of myth actually. So my topic is mostly a clinical based. The guidelines has been already spoken by all of my previous speakers. So I just go through quickly what are the different myths actually which is prevalent, and particularly these are very useful for our trainee, and this should be removed from their minds while treating or resuscitating a trauma patients. So the most important thing is that all the trauma patients, they need coagulation monitoring. So actually now as we move more and more ahead of the critical care advanced scenarios, so we know that the less is more in critical care medicine. So nowadays we don't have to resuscitate very aggressively, we don't have to give too much of fluid, and we don't have to do everything for that particular patient which is not required actually, just like Dr. Srinivas told regarding the pan CT scan. So that is the reason, so you have to individualize the trauma patient, you have to see what are the risk factors in those kind of patients, like whether the patient is a geriatric, whether the patient is a pediatric patient, whether there is an ongoing bleeding or whether the bleeding has stopped, or what are the risk factors, whether that patient is taking any anticoagulation, whether the patient is having severe injuries like extensive injuries, polytrauma. Those patients actually need a proper coagulation monitoring and point of care testing. So normally we send all the possible tests whenever we think that this patient might go bad, but actually that is not the scenario. So we have to see the vital parameters, we have to see the underlying comorbidity, and then we have to decide regarding whether this patient actually require a point of care, whether this patient require a dynamic test of coagulation, and then this patient require a proper, all the blood and blood product transfusions. So that is the reason you have to do a coagulation monitoring, but early coagulation monitoring is definitely a key. So the thing is that identify a patient, that those who are at risk of coagulopathy, and perform the initial basic coagulation test rather than jumping into all the possible investigations and making a huge bill, and which is a burden to the family and everybody actually. So interpretation of the results also very important, appropriate management involving proper appropriate blood transfusion and blood product transfusion is the key actually. And most of the time we think that if you replace more and more blood, actually the patient will get better, but actually that is not the thing. So that is the reason now the focus has been changing from the preemptive to the goal-directed therapy, and of course, I can also highlight the same thing that prophylactic blood product transfusions are always not necessary. We have to see, we have to justify. As far as possible, we have to avoid the transfusion, and we know that the transfusion itself carries a lot of risk, like it can create inflammation, it can cause transfusion associated circulatory overload, it can cause trally. So that is the reason, so individualized approach is the most important key to the critical care specialist, and that is the reason we are here actually, okay. And that other thing also you need to determine the transfusion threshold, and now most of the studies have clear-cut shown that keeping a transfusion threshold of 7 and keeping a transfusion threshold of 9 actually doesn't terminate into a lot of mortality benefit, and in fact sometimes they may be harmful. That is the reason, so coagulopathy should be monitored, and most of the times we see that the coagulopathy worsens over the time actually. So that is the reason it is a myth that once we monitor the coagulation, we don't have to monitor it regularly, but rather how we do our patient, how we manage our patient, how we do a point of care ultrasound regularly at every 6 to 8 hour interval or whenever the patient goes bad. Similarly, you have to see your patient and you have to monitor the coagulation factors, and you have to decide for the transfusions over a period of time. So you can see that the early stage, the coagulopathy may be mild, but it may be severe after some times. It may progress rapidly, and of course, late stage we don't have the time that much to resuscitate when the patient go into severe coagulopathy. That is the reason, so clinically every time you have to monitor the coagulation parameters. Then multiple transfusions, of course, this is one of the important myths that it reduces the mortality, but actually it is not actually. So we don't have to give multiple transfusions, just now I have discussed. So the fact is that most of the times in our mind that every trauma patient who comes to our ER, they may require a massive transfusion protocol. We sometimes inadvertently activate our MTP protocol, but actually it should not be there. We have to first see the patient clinical condition actually. What are the type of trauma, whether it is an ongoing trauma, massive blood loss, hemorrhagic shock, what are the type, grade, and then only you have to justify, and then you have to activate your massive transfusion protocol, because because trauma is a team effort, so we have to discuss with our surgeons. We are with all our emergency physicians and all our transfusion, your blood bank officer, and then decide regarding whether this patient actually really need a multiple transfusion or massive transfusion protocol, because then unnecessarily the resource will be wasted. So that is the reason, so it should be judiciously used, it should be goal directed, and it should be activated whenever it is required and not all the time. And always go for the alternative therapy to control the bleeding rather than going for blood and blood product transfusion. So that is the reason, so most of the times what we offer the patients, like there are a lot of therapies like the bleeding in the trauma can be controlled by medical therapy, surgical therapy, intervention radiologist efforts, and also sometimes by pharmacological therapy. So madam has already shown the importance of tranexamic acid is one of the good pharmacological agents. What I can tell you that there are a lot of local pharmacological therapy which is available to control the bleeding at the local site. Also there are a lot of medical regions, and you have to correct the medical regions, and you have to correct the coagulopathy, then you can achieve a good hemostatic measures. But whenever required, ideally the patient should be taken to the OT to control the bleeding. If it is a major bleeding, internal bleeding, or the bleeding which is not obvious but the patient is looking sick, particularly in the pelvic fractures, those kind of things, the intervention radiologist should be activated and the surgeon should be activated, and as soon as possible this patient should be wheeled into the operating room rather than taking all the patient to the operating room. And this is also one of the myths is that tranexamic acid is not effective, but it is definitely effective. Pre-hospital, intra-hospital, within 3 hours, it is very, very effective, and I think all the persons who are dealing with the trauma team and the trauma patient, they should know the role of tranexamic acid, because the trauma-induced coagulopathy and the bleeding in the trauma is mostly because of the hyperfibrinolysis. So there are two aspects of the DIC. One is called the hyperfibrinolytic variant, and second is called the prothrombotic variant. In sepsis, there is a prothrombotic variant of DIC, but in trauma, there is a hyperfibrinolytic variant of your DIC. That is the reason this drug is very effective, and it effectively controls all the fibrinolytic pathway which is which is responsible for causing the DIC actually. And of course the dose is 1 gram over first 10 minutes followed by the infusion. So that is the reason. So everybody should give the trauma patient whenever they suspect a severe bleeding, and particularly in the pre-hospital setup also. And the timing is very important, and sometimes there may be a contraindication. We just now listened, particularly sometimes it can cause thrombosis, and sometimes there is a history of thromboembolism. This drug may be sometimes little difficult to give, but of course this definitely a mortality benefit. So no trauma patient should be devoid of getting if there is a major hemorrhage, particularly in the pre-hospital and the ER. All the bleeding patients that require immediate transfusion. So this is a myth actually. So not all the patients. So you have to see the patient. So what is the severity of the bleeding? What is the hemodynamic status? Whether the patient is in shock, whether the patient is having severe tachycardia, what are the type of hemorrhagic shock, grade 1, grade 2, grade 3, grade 4, and whether that is a severe uncontrolled bleeding. So those patients require a bleeding transfusion, but not all the patients who are stable, who are young, who are particularly the vital parameters are stable and there is no obvious sign of bleeding in the clinical examination, in the ultrasound, or in the CT scan where the patient is absolutely stable. Those patients you don't have to transfuse them and keep them in trouble actually. The other fact is the calcium transfusion. So previously there is a myth that most of the times even if the patient has received a multiple transfusion, there is a hypocalcemia, but actually it doesn't affect the coagulopathy, but I can say it's of course affect the coagulopathy. I always insist my register to send two tests. One is the basic laboratory parameter along with your basic fibrinogen level and the calcium whenever the patient receives a multiple transfusion. And this is one of the observation is that most of the critical care when the patient is in severe surge response, in severe inflammation, the calcium level goes down. Calcium is one of the very vital agent to stabilize the platelet, to stabilize the clot, and to promote the hemostasis and to improve the coagulation factors. So that is the reason. So whenever we find that the ionized calcium levels are very low, actually we tend to keep it in the normal range, and we have to give sometimes the calcium infusions to keep the hemostatic mechanisms to work under proper care. Coagulation management is a one-time intervention, never, it is never. So basically you have to keep on checking the coagulation parameter, just like how we do a point of care ultrasound for a patient, how we assess the patient at regular interval, the trauma patient. We think that once the trauma patient gets stabilized, the patient can get better, but it is actually not the scenario. So every 6 hourly, 8 hourly, or every 12 hourly, you have to do a basic assessment, clinical assessment, the liver kidney profile, the underlying hemorrhagic status, and then you have to see for whether this patient is at risk of coagulation parameter or coagulation dysfunction, and then we have to supplement that with individualized approach. Rather than a common generalized approach, you have to go for an individualized approach, and we have to go plan a treatment protocol for that particular patient. So that is why the coagulation management involves resuscitation like permissive hypotension, sometimes damage control resuscitation, which can actually limit the IV fluid and limit the over transfusion to that particular patient. Temperature control to prevent the hypothermia, which will actually one of the commonest factor in the coagulation disorders. Surgical intervention whenever is required. Pharmacological management in the form of tranexamic acid, intervention radiological management, and sometimes the local hemostatic agents. And this is also one of the important fact that most of the times we think that the tourniquet what we apply, just a minute, so that usually harmful, but actually it is not the case. So whenever there is a long bone fracture, we have to apply the pressure, we have to stabilize the pressure, particularly in a case of pelvic injury, and we have to immobilize the pelvis. Then only the hemostasis will be achieved better. Aggressive resuscitation can lead to trauma-induced coagulopathy. Yes, of course, sometimes it may be, but this is not the only cause, because trauma-induced coagulopathy has multiple reasons. Basically, this is all related to systemic inflammatory response syndrome. We think that it is all because of the coagulation dysfunction, but actually it is due to endothelial dysfunction, and sometimes it can be because of the, sometimes called as the release of lot of procoagulant factor or anticoagulant factor from the systemic circulation. This is just like a liver patient who normally bleeds, but most of the liver patients, they tends to clot also. The same thing happens with the trauma. So that is the reason trauma is a syndrome. It is not a disease. This is called the polytrauma syndrome. That is the reason whenever we have to see a trauma patient, we have to look at all these aspects. This is also a common myth. Actually, hypothermia is the only cause of the coagulopathy, but it is actually not. There are multiple reasons like your acidosis, your hypothermia, your aggressive resuscitation, your sometimes called as the underlying patient condition. So all these things to be taken into account wherever we are treating the patient. Isolated traumatic brain injury doesn't cause coagulopathy. It is again a myth. Most of the time patient with isolated head injury doesn't present with a shock, but they can present with lot of coagulation abnormality because of the systemic inflammatory response syndrome and something called as the inflammation and tissue injury. So with this, just I would like to conclude my talk, and my take home message is early recognition is the key, early assessment is the key, and repeated regular assessment of the trauma patient in the ER and in the ICU is the key. Massive transfusion protocols should be individualized rather than a preemptive. Point of care testing should always be advisable whenever the patient is in severe ongoing bleeding. There the statics test doesn't actually give us much idea. Monitoring for the complication is a must, and always multidisciplinary approach is the key to your trauma patients. So thank you.
Thank you, Dr. Gunadhar, for the crisp the talk. So quickly we'll go to the next talk. The talk will be on the post-cardiac arrest neuroprognostication. So it's always a challenge for us to prognosticate the patient, especially when the patient is having a deeper coma. So to deliver the lecture, I invite Dr. Deepdipa Devaprasad, lead consultant from Chennai Apollo. It is always good and nice to hear to you, sir. Thank you very much.
Thank you. Good morning. Thanks to the members of JIGS for having me here. In the next 12 minutes, I'm going to talk to you about how to prognosticate patients after a cardiac arrest. Now, if I were to ask you which features of a neurological examination of the comatose patients are predictive of outcome, GCS score, how many of you would say the GCS score? Yes, if most of you would say yes or no. Okay. If you look at the GCS score, not all components of GCS score are important. The E and V are not important. It is the M component that is important. So the motor component of the GCS is important. Among brainstem reflexes, pupillary right reflexes, corneal reflexes are important. Eye movements are not really important. And we'll talk a bit about seizures or myoclonic status as we go around. So the first ever attempt on neuroprognostication was laid by a guideline that came in 2006. That's the first time that neuroprognostication had a formal guideline. Though from 2002, following the HACA study and the Barnard study, which looked at a mortality benefit from hypothermia, even at this point of time when they conclude the study, not many patients had undergone hypothermia. So most of the prognostication that happened based on this guideline were taken from patients post-cardiac arrest who had not received hypothermia. So that's where this guideline did come up at that point of time. So let's pause back and think, why do we need to prognosticate these patients? Well, let's look at two reasons. In the Western world, Europe, you're going to prognosticate because if you're not going to prognosticate, this particular patient is going to occupy your bed for maybe a week, for maybe a month, which means you're going to deprive another patient who's in need of bed of a better care. So that's why they need to prognosticate. And in India, where you had a survey just a few days ago saying that 90% of the payment is from in-pocket. Insurance is only 10%. And you know how much impoverished the patient's family can become in caring for someone who's going to be a vegetative person. So therefore, it is very important that you prognosticate. But then you have to get it right, because if you don't get it right, it will be a self-fulfilling prophecy. If you say that someone is not going to have a good outcome and you pull off the plug, he's going to die, and you are nowhere going to know whether you would have had a good outcome when you waited for 3 months or a year after that. So you can't be a self-fulfilling prophecy, and therefore when you are neuroprognosticating these patients, there can be no chances for error. It has to have a false positive rate of 0%. So if you can look at the columns here, the triangles here, you can look at the false positive rate of all the criteria that have been laid out. The false positive rate is around 0%. Some it's 0 to 3, some it's 0 to 8.8. That's the range. But most of them it approximates or comes to 0%. That is why these are the only criteria that are laid out for neuroprognostication. So what are these criteria? These criteria are clinical criteria. Criteria are lab criteria. Lab criteria is either you look at the SSEP in the neuro lab, or you send a serum sample for an NSE into your biochemical lab, and of course the EEG. You can do it anywhere between 1 to 3 days. On day 1, you're looking at the EEG and saying whether the patient has got status myoclonus. If status myoclonus is present, the patient has got a poor outcome, and that false positive rate is 0, somewhere between 0 to 8.8%. That is it. Between 1 to 3 days, you could send the lab parameters, which is looking at the SSEP, which is an absent N20 response, and serum enolase, and if it's more than 33 picogram per liter, it shows that these patients are likely to have a poor outcome. There again, the false positive rate is around 0%. And after day 3, you're looking at 3 clinical signs: the pupillary signs, the corneal reflex, and the motor response. And motor response, we are looking at M1 and M2. So you either have an M1 or absent motor response, or M2, which is to have a extensor motor response. So if you have a bilateral absence pupillary reflex, a bilateral absence of corneal reflex, or an M1 or M2, you do have a poor outcome. And that was what the 2006 update did give us. Moving forward, we went to the 2015 guidelines. I'm not going to go into how the guidelines evolved, just to let you know that the guidelines, by this point of time, you had a significant number of patients who received hypothermia. And therefore, you need to have this modification. What does hypothermia do? Sometimes when you have a hypothermia, you can recognize that these patients, if they're going to be tested for neurological function, the hypothermia may depress the neurological function. So you cannot obtain your SSEP or your EEG upfront. So you will have to obtain your SSEP or your EEGs only after these particular patients have been rewarmed. So 1, 2, 3 and 3 had to be pushed back by a day. That is a day after you reached your hypothermia. So it became day 2, 2 to 4 and 4 days. So just to get your maths right, so if you are saying that neurological examination is on day 3, which means if you have received hypothermia, it has to be after day 3, that is between 72 to 96 hours. So that's very, very simple of when do you want to prognosticate. But then this also looked at the criteria and examined these criteria more strictly and stringently, and identified certain criteria that are more useful and some criteria that were less useful. And they also said at this point of time, if you're seeing a patient who's got an ST elevation and his comatose, rush him to the cath lab, open up. If you have a patient who's got an ST depression, it is possible that he has a coronary artery disease, so take him to the cath lab. And most often than not, you have a patient in whom you have not been able to attain an EEG and you have obtained a ROS, but you clinically think that he's got a cardiac event. Please take him to the cath lab and open it up so that you can prognosticate later. So that's something that they also wanted to really look at it. Okay. So here again, they're looking at the pupillary reflex. Pupillary reflex, irrespective of whether you've done your TTM or not done your TTM, you're going to do it after 72 hours or 96 hours. Here, this is the first time that they looked at the other clinical criteria and saying, yes, M1 and M2 response is bad, but if you're going to look only at an M1 and M2 response in isolation and going to prognosticate that these patients are going to have a poor outcome, then it is not right. So they said clearly that it is unacceptable that you use the absent motor response or an extensor posturing alone as a criteria for neuroprognostication. You can't use this clinical criteria alone. Pupillary reflex, you can use it alone, but an M1 or M2 response alone cannot be used as a criteria for neuroprognostication. And how many of you would see that if you've seen patients with myoclonus, how many of you will say that they will have a bad prognosis? Just a show of hands. Yes, most of us would say. Believe me, I've seen 3 patients who've had myoclonus at least for a week to 10 days, and 3 of them had survived to home discharge. 3 of them. And all the 3 of them are patients with post-traumatic brain injury who had a surgery. So they've had injury to the brain, and on top of it, they've had a cardiac arrest and they've had myoclonus. And therefore, it is very important for you to understand that simply because you see a clinical myoclonus or a stimulus-induced myoclonus or myoclonus that is ongoing, don't prognosticate. If this myoclonus is also reflected as a status myoclonus on the EEG, only then it is reflective of a poor prognosis. So don't look clinically at a myoclonus and say that this particular patient is likely to have a bad prognosis. You will have to confirm it. If your EEG is also showing a status myoclonus, then you could have a bad prognosis or a very, very poor outcome. And there have been two additions that the 2015 guidelines came. One is to add some more criteria to the EEG and also include neuroimaging as a part of the criteria. So what did they add in the EEG? They said that if your EEG shows that you have a burst suppression or it is a non-reactive EEG, then again it is likely that this particular patient is having a poor outcome. And if this particular patient has got a persistent refractory status epilepticus, there again this particular patient is likely to have a poor outcome. So that is another thing that was added into this. And here again they said that if you have a CT scan that showed, we talked about new additions, one will be on a CT and one will be an MRI. If you have a CT scan that showed a great wide differentiation that is lost extensively, that can be detected as early as 2 hours, that again shows a poor prognosis. An MRI that shows that you have a restricted diffusion weighted image again shows a poor prognosis. Now we go into the 2023 update, and this update is even refined this further. We are not going to look at who are going to have bad outcomes. We are going to look at the reliability of each of the criteria. And how did they determine the reliability? They called it very reliable if the false positivity rate was less than 3%. So if you're going to have a false positive rate of 0 to 3, then it is reliable. If you have a false positive rate about 0 to 5, then it is moderately reliable. If you have a false positive rate that goes beyond 5, then it is non-reliable. And here again, they looked at the previous updates and they also added two important things. Until now, we've had data only to say who's likely to have a poor outcome. I cannot say who's likely to have a good outcome. Here, they started to really introduce and say, if I see these criteria in these patients, it is likely that they may have a good outcome. And what are this? Just to let you know, age is not a criteria to prognosticate. Just because someone is elderly and has had a cardiac arrest, don't say that he's going to have a worse outcome. The initial cardiac rhythm, shockable or non-shockable, doesn't determine neither the time for obtaining ROS. It is not the time for attaining ROS. It is the quality of the CPR that the patient has received at the time of suffering the arrest that determines the prognosis, not the time of ROS. Of course, if you have a prolonged time, maybe the quality of CPR, just a minute more. Yeah, I have a minute. The quality of CPR may vary, and that is why you may have a poor outcome. And of course, the rest of the things were the clinical criteria that were listed out. So just to let you know, poor outcome, very likely, but some uncertainty exists. That is your reliable criteria. Poor outcome, likely, but significant uncertainty exists. That is your moderately reliable criteria. And everything else is indeterminate. And if you look at the middle box, the third box, it says indeterminate, but good outcomes most likely. I'm going to conclude by looking at what are the good outcomes here. So these are the different guidelines, and I think I'll just summarize what was shown in the previous slide in this particular slide. So we now know what were the 2006 updates, we now know the 2015 update. Now I'm going to look at the 2023 update. In the 2023 update, what is reliable? If you have a bilateral absence pupillary light reflex at 72 hours, most likely this patient has got a poor outcome. If you have an SSEP that is absent N20 response at 48 to 72 hours, poor outcome. If a patient has got a CT that is showing a great matter differentiation, or an MRI that is showing a restricted diffusion, or an EEG that is showing myoclonus or a burst suppression, they are still only a moderately reliable criteria. The motor response alone is not a criteria. And remember, the corneal reflex which was originally noted and the N20 and the serum enolase or NSE that was noted still no longer exists in the newer criteria. And what is likely to tell us about a good outcome? It is the motor response. Motor response is to say that if the patient has got a withdrawal localization, then he is more likely to have a good outcome than a poor outcome. And if this particular patient has got no changes on the MRI or has got very isolated changes on the MRI, very isolated, they are not defining how much isolated, 1, 2 or 3, it's still not been quantified, but if we're going to have very isolated changes of DWI changes or restricted diffusion in the MRI, shows a good outcome. And if you have an SSEP, that is more than 4 millivolts at 48 to 72 hours, then again it is good outcome. And thank you all for your patient hearing.
Thank you, sir. Thank you very much for the crisp and clear message what you have given us. Thank you very much for your presentation. So actually to have a last talk, and we have a talk on role of fibrinogen concentrate in a bleeding patient, and by Dr. Rahul Pandit. Unfortunately, sir has not come, but he is kind enough to send his recorded presentations. And can we have the recorded presentation here? Dr. Rahul Pandit is the chair critical care, sir, HN Reliance Hospital. Till the presentation is getting loaded, we can take maximum 1 or 2 questions. Anyone have any questions? Any of our
Fibrinogen
speakers?
as a critical factor in hemostasis and how we can use fibrinogen concentrate in some of the cases which we routinely do in intensive care unit. I at the very first thank the organizers for actually inviting me. Unfortunately, due to a very late arrival of flight yesterday, I couldn't come across to Bangalore, and I'm thankful that I'm actually able to join you virtually on this talk. So, if you look at fibrinogen concentrate, it's got a diverse role in hemostasis. It basically targets platelets for aggregation. Approximately 40K to 80K fibrinogen molecules can bind to a single platelet, and hence it increases the clot strength. When you have a fibrinogen concentrate level or fibrinogen level of more than 200 milligrams per deciliter, the clot strength is good. Also, it sort of represents the whole amount of weight of plasmatic coagulation factor, and it is the first one to fall below a critical level during bleeding or hemodilution. Hence, I think it plays a very important role in the entire hemostasis, which we all know of. If you look at the normal values in the blood, the normal values in the blood are around 1.5 to 4 milligrams per deciliter. And when it falls below 1.5 to 2, we call it as acquired hyperfibrinogemia. And you have a severe deficit when it falls to around 0.5 or so. So I think we need to understand that there is a critical level of at least 1.5 and above, which needs to be kept up. When we look and compare it with the blood products which are available, the FFP, cryoprecipitate, and fibrinogen concentrate, comparing each other, you can actually see that the dose of fibrinogen to be basically increased, you would only require 2 units of 1 gram of fibrinogen concentrate. As opposed to that, you would have 10 to 20 bags of cryoprecipitate, and you would need at least 30 mils per kilo of FFP, which is around 2000 ml, to have an equal amount of fibrinogen replaced. The best thing is that it is widely available now in India as well. It was easily available in Europe and many of the other first world countries, but it's now available in India. Of course, cost is a factor which we need to consider into the picture right now. Now, what does this fibrinogen concentrate actually do when you have a bleeding patient? The important thing is that when they looked at these 89 surgical severe bleeding events in around 12 surgeries, they found that when the fibrinogen concentration was used in these surgeries, there was a very, very good intraoperative and postoperative success rate with the treatment of fibrinogen concentrate. And more importantly, there were no adverse effects in form of allergy or hypersensitivity or death. And there was no clinical evidence of neutralizing anti-fibrinogen antibodies, which I think is very, very important to understand, that it is actually doing its job but not causing a lot of complications. If you look at trauma-induced coagulopathy, we see that the problem in trauma-induced coagulopathy is because of shock and hypotension, there is a significant rise of protein C activation, and the glycocalyx obviously becomes dysfunctional. When you add a fibrinogen concentrate to this, it actually makes a big difference, because the fibrinogen levels go as low as 1.5 grams per liter or below in these trauma patients who have a significant amount of trauma. Add to this acidosis, hypothermia, the lethal triad, and coagulopathy keeps on worsening as the trauma patients bleed more and more. So the European guidelines in 2019 actually said that while you are waiting for thromboelastogram or ROTEM results or the laboratory results, in the severe trauma patients, you can actually administer 2 grams of fibrinogen, which will sort of mimic a 1:1 ratio in the which is basically equivalent to giving 4 units of RBC along with that a 1:1 ratio of your coagulation factors, which will correct the hyperfibrinogemia which is present and thereby decrease the bleeding complications. Also, in patients with pelvic fracture, Japan actually came out with a reasonable guideline. Before April 2023, the guidelines actually said that order 10 units of red cell concentrate, 10 units of FFP, and 20 units of platelet concentrate if required. However, since the 2013 guidelines now, they basically ask you to administer 3 grams of fibrinogen concentrate, because what is well recognized is that the fibrinogen levels do drop down below 1.5 when you have severe trauma. Does it actually improve your outcome? The single center study, which actually showed that in severe trauma patients, they had actually a very good improved outcome here. And you can see the Kaplan-Meier curves separate out pretty quickly in the fibrinogen concentrate group. And the in-hospital survival when compared to the control group was significantly better. So I think there is some evidence that if you have a trauma patient, you administer fibrinogen concentrate early on, you probably have a better outcome. And of course, a single center study does not relate to a practice change, but it certainly points out that there is some signal there which you could utilize in your group of patients. Another one from Germany. This study did not look at your mortality, but it sort of looked at the transfusion requirements. And if you can see this bar graph here, in the first one you can see the number of cases in the dotted line here, followed by the red cells, FFP, and platelets. And when fibrinogen concentrate was given to them, there was a significant decrease in the amount of blood and blood product requirement, with the blood product requirement going down by almost 33% across the cases. So I think there is a reason to understand that if mortality may be a question, I believe we don't have enough data to say that it's a practice changing one, but certainly there are studies after studies from single center and multiple centers which talk about reduction in giving blood and blood products, which by itself will actually cause lesser and lesser complications. What about postpartum hemorrhage and DIC? Well, in postpartum hemorrhage, you have multiple factors which it could be triggered by: amniotic fluid embolism, abruptio placenta, sepsis, too much of blood and blood products being administered, IV fluids being given causing dilutional coagulopathy, and of course, the DIC triggers by your global tissue factor. Tissue factor is then expressed onto the cells, and then that sort of keeps on worsening as the DIC progresses. You have more and more consumptive coagulopathy and bleeding. While we all know that this can be a problem, we also know that there are low levels of fibrinogen, and the odds of severe PPH in these patients is probably a bit higher. So, specifically, a low level of fibrinogen is probably identified as an important predictor for severe PPH. And for each gram per liter decrease in fibrinogen, there's almost a 2.5 times, 2.5 folds increase in the odds of a severe PPH. Specifically, if the level is below 2 grams, I think the prediction of having a severe PPH in this patient group is almost 99%. So what do we do? Now, you've heard of this concept of a shock pack. A shock pack is made up of 4 units of FFP, 4 units of red blood cells, and 1 unit of platelet. If you were to use a shock pack, and then with ROTEM, you came to know that your FIPTEM, which sort of determines whether you're a fibrinogen activity, FIPTEM A5 is less than 7 millimeters, or it's between 7 and 12 millimeters. That means there is an ongoing risk of hemorrhage. If you give these patients fibrinogen concentrate, there is significant reduction in the amount of blood products and total volume of blood products which is being used. So ROTEM, or a thromboelastogram guided therapy, will definitely bring down your blood product requirements. Certainly, when you are using these blood products for various levels, for example, if you have blood platelets of less than 50, you would probably give 1 to 2 platelet concentrates. If you have a fibrinogen of around 1 to 2 grams, you may give 10 units of cryoprecipitate. Instead of that, if you could just replace that with fibrinogen and have, instead of FFP and cryoprecipitate fibrinogen given 2 grams, it will actually not only improve the levels of fibrinogen, but will also bring down your blood component requirement. So if you look at this graph here, bleeding If it's a minor bleeding or no bleeding, you probably don't need to do anything. But if the bleeding is major or there's a need for an invasive procedure, you consider giving fibrinogen. And each gram of fibrinogen basically 30 milligrams per kilogram of fibrinogen will actually increase your fibrinogen in the blood level, plasma level by 1 gram per liter. So I think it's very important to understand that you're avoiding blood and blood product transfusion here. Am I a proponent of fibrinogen? I've been using it now for some time. We used it extensively in one of the hospitals in Australia where I worked as a locum in the rural part of Western Australia. For almost a year, they were exclusively using only fibrinogen concentrate, and the use of FFP in that hospital had come down next to nothing. So I think there is a widespread use of this, and trying to avoid blood and blood products is what we should be aiming for instead of improving the mortality. Um, Now, if you have patients who are bleeding, or if you have patients who have already lost more than a liter of blood, then I think again fibrinogen concentrate in the dose of around 30 milligram per kilogram should be given based on your ROTEM or your thromboelastogram. Now, what happens when you actually have a cytoreductive surgery for pseudomyxoma peritonei? A pseudomyxoma peritonei, which is a very aggressive form of a malignancy, for which a large number of centers do something what we call a peritonectomy with HIPEC. You can see that these patients were randomized and were prospectively studied by a 2020 trial published in the thrombohematogram by Ashok Roy. They gave uh, basically 4 grams of fibrinogen concentrate or cryoprecipitates were given in two pools of 5 units each. And you could actually see that when they were giving cryoprecipitate versus fibrinogen concentrate, it was actually a comparable chart when you're comparing both together, except that there were some embolic phenomena which were seen more in cryoprecipitate group. Otherwise, the safety was reasonable for this molecule. Similarly, in liver transplant as well, we all know liver transplant, there is a lot of problem with the thrombin burst, which happens due to the liver trauma. And if the patients have a perioperative low levels of fibrinogen, it is associated with a significant amount of bleeding complications. So if you give fibrinogen concentrate a little bit before the surgery and try and keep the levels around 1.5 to 2 grams per liter, the bleeding complications come down. How do you do that? You can actually use ROTEM and ROTEM guided therapy to study for liver transplantation. And when fibrinogen concentrate was administered with in patients who have a FIP-TEM of around 6 millimeters or so, those patients had a significantly less requirement of RBCs as well as fresh frozen plasma. This is how you would want to do a timing of your ROTEM in the orthotopic liver transplant, and you would be able to then decide when do you want to give a fibrinogen concentrate. What about safety? Safety in patients with coagulopathy with surgery. I think there is significant amount of data now from various centers where they have talked about the level being about 1.5 and above, and you have a reasonable safe with very, very little complications which would be happening. Similar data is coming out from surgical cardiac surgery and trauma as well. I think there is a ROTEM guided therapy which can be used for patients who are bleeding after a cardiac surgery or during a cardiac surgery, and correction of fibrinogen concentrate by using the FIP-TEM of around 6 millimeters or so or more would be something which would actually help you to guide the fibrinogen therapy. What about centers who don't have TEG or ROTEM? The current consensus seems that instead of transfusing fresh frozen plasma or cryoprecipitate, you could actually transfuse fibrinogen concentrate if money is not a problem. And the fibrinogen concentrate aiming at bringing the fibrinogen level greater than 1.5 grams per liter, which will help you to decrease your blood and blood product requirement. What about thrombogenicity? Anybody who is giving fibrinogen would want to know what is happening with the complications. Well, there is again a significant data which is coming out from retrospective analysis. Around 5,400 odd patients who received fibrinogen concentrate compared to those who did not receive. The primary endpoint was to see thromboembolic complications and death within 1 year of surgery. And there were secondary endpoints as well, which was composite and mortality, composite outcomes and mortality within 30 days. And what was found out was that perioperative fibrinogen concentrated bleeding cardiac surgery patients is not associated with the increased thromboembolic complications or death. So I think that's reassuring. This study is published in 2020. Again, what about some safety in terms of allergy and thromboembolic complications in PPH? Very, very good data coming out. There is hardly any complications I've seen there. So I'd like to conclude, my friends, that the fibrinogen supplement, which is being used along with Frotem or TEG, would bring your blood and blood product transfusion down. It is rapidly available and easy to administer. The best part is that you avoid volume overload risk and TRALI and other complications which are caused by that. It has a low thrombogenicity as opposed to some of the other procoagulant factors like activated factor, uh, like factor 7A. And of course, you don't have inhibitor development, which is known right now. So I think it's very safe to be using it. I'll be happy to take questions. Thank you very much again for the invitation. Thanks. Bye.
So, thank you very much. For want of time, actually, we won't take any questions. I do hope that you may have a lot of burning questions. We can catch up our all speakers who will be available with us. So I will formally close this session. Thank you very much. And thank you all speakers for their dynamic and excellent deliberation. And